overview of the program, and then we will move on to the first topic of the day. So the whole idea of the program called Master Trainer Program is to give you actually three things. One is content. So content I have already shared with you, which will help you to design your programs independently. So at least the basic content is available with you. And most of my presentations, I have kind of, put in the word form so that you can use and, modify and match as per your requirement. This second part is about delivery. So basically, when we talk about Master Trainer Program, the expectation is that person who takes this program should be able to independently conduct training programs on clinical communication. So one is that since you will be observing me doing this training program, so hopefully there'll be a lot of learning, then we will interact and we'll discuss and, use different pedagogies. The third focus area is going to be the pedagogies of training, because a lot of you will have almost every information or knowledge because it's already available on Google, and many of you have already done your training with Kaho, and otherwise also you have attended a couple of programs. But in this program, we have integrated the pedagogies in a manner that one, we will be having a discussion around different pedagogies under the topic facilitation skills. So the 10 sessions that we have designed, first two sessions will be on introduction of communication, which may be new to some and familiar to some, but just to bring everybody on the same page, we will have that basic topic today. The next topic will be on the developing communication competencies. Again, that will be verbal and non-verbal communication, but we will do it through activities and participation. So there will be good, rich learning in that. Session 3 is focused on designing a program. So the idea is those of you who wish to become trainers, they'll get an idea, how do I really design my program? And those of you who are not going to directly train, but if you have an idea, how do you really go about designing a program? You'll be able to make sure that your team works on the right structure. So we'll be talking about how do you design a program. Session 4 will be purely on facilitation skills. So as I said, many of you may be very experienced, seasoned trainers, but many of you may have the knowledge, but when it comes to actually conducting the training program, you may have difficulty. How do I go about, conducting a program? So facilitation skills are all about how do you really make sure that you're able to engage your audience? Where do you put storytelling? Where do you put, experience sharing? How do you break the ice? How do you make people, engage with the program? All that is going to be discussed in session 4. After session 4, the next 6 sessions, I would be taking one topic each from the clinical communication. For example, breaking bad news or updating the family of a critically ill patient, or how do you handle complaints? Then also, how do you handle aggressive patient party? Disclosure of medical errors. So all these topics we are going to cover one by one in each session. But besides that, I will be sharing a list of different pedagogies from which you will have to choose one pedagogy that you would like to showcase. So your task will be to prepare a 15-minute presentation on that pedagogy and make a presentation one by one. So we will have 2 presenters every time because we will be left with 6 sessions. So we need to cover 11 participants. So in every session, we will request 2 participants to make their presentation. I will be working hand in hand with you to make sure that the pedagogy that you share with the group is standardized and we are able to give the detail that we need to share with the participants. So one is you will get to learn to practice and also showcase one pedagogy, and all of us will learn from each other's experience. So almost like 11, 12 new pedagogies will be learning. For example, storytelling can be something that you have seen, but we haven't learned in a structured manner. Or role plays we all know, but then still, if we know the proper way of doing it, structured way of doing it, then probably we'll be better equipped with doing it. So similarly, each one of you will be choosing one pedagogy and making a presentation. And simultaneously, half the time I will be utilizing for delivering the topic so that you get to, familiar with the topic. And in between, in case if you want any particular topic to be covered or any area to be focused, we can always pick up in the same session or maybe in the next session as per group's requirement. So this is kind of a unique program that we have designed to make all of you at least use that title of master trainer in healthcare communication. Although many of you are not going to be trainers, but that's how we have structured. So any doubts or any questions about this strategy or anything that you wish to comment? You're okay? Everybody's okay with this? Okay, thank you so much. Thank you so much. Okay, so going ahead quickly with the first topic of the program, and that is relevance of communication in healthcare. So I want to really ask all of you, what is your understanding of the relevance of communication in healthcare? So if I mean one by one, if you could raise your hand so that I could request you to share your thoughts about it. So what is the relevance? What is the importance? And why suddenly this has become such a big issue? I mean, 10 years ago, we never talked about this. Today, we are really, undergoing programs to learn the right way of communicating. So why this change? Go ahead, please, Dr. Anuradha.
Yes.
Yeah.
Communication nowadays very important to understood the issue with the patient and family, as well for the better outcome. For example, when you are receiving any patient for the surgery or emergency, anything, or day by day, if you are not committing the clinical issue with the patient and patient got deteriorated by the condition, then it will be the very painful situation for the relatives to understand their financial issue, the clinical outcome, everything. So nowadays, nowadays every people they are aware about the medical laws and the other act. So every single day, they are raising the question why it is happened with the patient, why it is happened with this treatment. So nowadays, clear clinical communication is very much important in the healthcare industry.
Wonderful. Thank you, Smishta. I think you have pointed a very right listening point that patients and their family members want to know in detail about the patient's condition or the outcome or the different options available. So it's time that we need to be, conversant with the idea of how do you really go about explaining them. Thank you so much. Dr. Anuradha, you wanted to say, so sorry you were stopped. Yeah, please go ahead. Yeah.
According to me, the power of communication is very strong. Half of the treatment is done by the way we communicate to the patient, the disease itself, and the mode of treatment that we are going to have. The details of the mode of treatment nowadays, because of the Google, as the patients are doing their own Google survey before they come to the hospital, especially for the operative treatments, and if they are hospitalized, the diagnosis they know, they would detail it through Google, and then would want to understand how this doctor is going to take care of me or my patient. So I feel that it is very, very important to clearly communicate the disease, the prognosis, the mode of treatment, the time of stay, which is a very apprehensible thing for a doctor to disclose in the immediate and like in the beginning only, and how the treatment can take turn in any direction, and to be very open with the finances of the financial cost that it will cost to them also. If we are very clear with the patient from the beginning, the rapport between the patient and doctor is very good and it progresses very smoothly. Otherwise, other actions which we see nowadays happen can take place. And because of the pandemic, I think it is more important they have understood the value of a doctor as well as the value of life is more now in relation to what we had earlier.
Thank you. Thank you, Dr. Anuradha. Very rightly pointed by you. One is patients see your communication skills more than your clinical skills. And it's not me who is saying it, is the studies that say that patients see your communication skills more than your clinical skills. And that's the reason probably quacks are doing better practice than the clinicians, isn't it? So I think we really need to understand the importance of communication, especially since it has become a paid service. Earlier, it was more like, a social service or a government funded service. So it was never, nobody demanded any quality or quantity or participation. But today, once they're paying, they want value for money. So which is absolutely, fair on their part. Thank you so much. So Dr. Bala, do you want to add something new to what Dr. Anuradha or Smishta has added? Do you have anything new?
The patient expectation and patient experience is dynamic and it's keep on changing every time.
Very
so we
right.
have to be very careful.
Very right.
Yeah.
Very right. So that means patients' expectations are changing every time. The moment they come in, they are very different. After they are feeling comfortable, their expectations are different. And then once they are admitted there, they expect something more. So we really need to be, watchful of all those changes, and we need to be ready to proactively meet those expectations of the patient. I completely agree with you. Thank you so much. Anybody else who has something new to add to why we need to today work on communication? Yes, Dr. Pai, please go ahead. Yeah.
Yeah, earlier, the earlier practice of paternalistic attitude, like the doctor will decide everything for the patient, and the patient will, just accept whatever treatment he decides, is gone. Those days are gone. Now the patient wants to have an active, part in the treatment of the patient, and because there are so many options available, for different treatment modalities. And secondly, since medicine is not an exact science, it's not like 1 + 1 is 2. So
Yeah.
there is always a big risk involved in any treatment,
Yeah.
and you can never predict who will get a complication and who will not get. That no doctor can predict. So that uncertainty creates, the need for good communication.
So there's a saying that good
Yeah.
communication is for the rainy day. If you have
Yes.
built good rapport with your patient, if you have good, understanding with your patient, it definitely, when the time would be challenging, they'll stand
Yes.
by you and rather not, drag you down. Very rightly said by you. And today, patients want to, they want to know about what is going on with them. Like earlier, we used to say we will decide on your behalf, but
Yeah.
today they are not okay with the idea of we deciding on their behalf. They want to take charge of their life, and they have full right. That's one of the patient's right to choose what they want and what they don't want. Thank you so much. I think good point. Anybody else who has something new to add to the discussion?
Just a small word. I mean, having been into admin, whenever there is a major complaint which cascades into a medical legal issue or something, we normally, ultimately it is traced back to some or the other communication, little bit of it here and there. So I have seen out at least 8 out of 10 times it is. So that's where I feel that, it is very, very underrated kind of a thing. Yeah.
Yes, I think communication is the basis of all interactions. And the major patient satisfaction comes from the communication and the behavioral skills of the doctor and the whole team, as in total. So I think that's a very important thing, very rightly said by you. Any other point, if anybody? Yeah, Dr. Pai,
Yeah.
you I think you
I
want to say
think
something. Yeah.
I think in 1985 or 87,
Yeah.
I don't know exactly. Maybe Dr. Sandhya, Captain Sandhya can help me. The healthcare was brought under the purview of Consumer Protection Act. So I think from that time, everything changed. Before that, it was patient care is with a doctor's mandate,
Yeah,
and the
prerogative.
patient has nothing to prerogative. Yeah, yeah.
Yeah, very true. I completely agree with you. So what all ill effect are you seeing today because of the communication failure? Dr. Saifuddin, I want to ask you about your country. So what is the situation there, and what ill effects are you seeing out of
Yes,
communication failure?
I think I should state some retrospectively. There is importance of communication. Because of poor communication, there is a creation of trust crisis between the care receiver and the caregiver. And because of the trust crisis, there is lots of financial draining to abroad. For example, India is the biggest service provider for Bangladeshi healthcare service receivers. And when we do ask the patients who came back from India, they never tell us about the technologies or the sophistications, but about the communication and the behavioral aspects. So that's the most important one. And not all the Indian hospitals are inviting or getting patients from Bangladesh, but the institutes that focused on communication, more importantly, they are getting patients from Bangladesh. That's number one point, trust crisis and the financial draining. Number two, because of the poor communication, there is huge diagnostic error. So what we experience, my disease was not diagnosed in my country, but when we went to India, my disease was diagnosed. So why the disease was not diagnosed? Because of the poor concentration or poor communication.
Very
Just
true.
two things.
Completely agree with you. Most of the diagnostic errors are because of taking incomplete history or not listening to the patient or not understanding patient's point of view. I completely agree. But I'm thankful that you are saying that people coming from Bangladesh for treatment to India and going back, they appreciate the communication of our doctors and our team. I'm really very happy and thankful to you. So I think at least partly we are on the right track, I can say so. Yeah, Dr. Captain Sandhya, you had something to contribute. Please go ahead. Yeah.
Yeah. Although it is already said, and since we have evolved and look back, since we started, serving the healthcare, the most important thing is 75% coming from the private sector. There is nothing as important as communication, written, spoken, both as as important communication for us especially. And now it is very well realized with aware consumers, number one, and demanding consumers.
Yes.
Aware consumers applicable to both public and private sector, and demanding consumers for the primarily for the private sector. It has become a
It's both ways now, even in the public
need.
sector.
It's become a need. The amount
They
of
come and say on the face, the salary that you're getting is being paid from my, income tax. So you're not giving me a free
everybody
service.
here sitting here will relate the way we always feel तलवार की धार पे रख के काम करते हैं हम.
I completely agree. I completely agree.
So communication is like now, people should see it as their bread and butter now.
Yeah, that's true. That's true. So let's quickly have a look at a presentation that I'm going to share with you. It's about, we are trying to just understand how communication has changed now and why it has changed, and then what we really need to do. So let me share the screen with you, and we'll have a lot of activities even in that presentation. So it's not just presentation, but we are going to have, a discussion around it. Give me a second to share the screen. Okay, so is the screen visible to all?
Yes.
Okay, thank you. So as very rightly said by Dr. Pai and many of you, that practice of medicine was much, much easier and simpler earlier, because patient had a lot of faith and they just believe that whatever doctor will say or do is final word for me, and that's going to be for, for my good. So I just have to blindly trust the doctor and follow the instructions. But I think time has changed over the last couple of decades, I can say so, and which is further deteriorating. And some of the reasons that why this, change in the relationship that has happened between the patients and the healthcare provider is that there's a change in their awareness level. So many of you said that they have access to Google, they can now get information, they know what are the options available for treatment or what are the possible outcomes or the risks involved. So naturally they have become more aware of it. I was asking, I asked one of the doctors, very senior, doctor practicing in India, in Delhi. So I asked him, how do you find people coming up to you with information from Google? So before I answer what he said, I want to ask all of you, what is your feeling? How do you feel when you see them, coming up with the questions from Google or information from the Google? So how do you feel? If somebody would like to respond to this.
I would say it is frustrating. It's irritating.
It is frustrating.
It's irritating.
And believe me, very surprisingly, the doctor said, I really enjoy people coming with Google information. I was surprised. I said, how come? He said, Google really helps me. The idea is they already have some information. And when I talk to them about their treatment, and if they ask me, is there any risk or is there any, what is the prognosis? I tell them very clearly, you have read Google, so you must have seen the risk involved in this surgery or in this procedure. So in a way, Google helped me validate my point by saying that everything is already available on the Google and you can see and read and find out. Another thing that he said, GPS. If GPS is available, will you not use GPS to travel? Yes, I think we all will use GPS. Trust me, even if I have to go to the same destination, I always have my GPS on, because at least it saves me time and it takes me from the route where I will spend least time to reach my destination. So the idea is, he said, if there is GPS, people are likely to use GPS. Similarly, if there is Google, people are going to use Google. You cannot fight with Google, but you can actually make sure that even if they come back with a lot of questions from Google, you know how to handle them. So the biggest challenge is when they ask little more than one or two questions, we are very uncomfortable and we don't like them asking us a lot of questions. As very rightly said by some of you, the demands and expectations have gone up. Like Sandhya ji was saying that they are very demanding now. Naturally, if they are paying a lot of money for a service, they are bound to ask us for the value for money. See, even if we go for a cup of coffee, or if we go for dining out, we expect best of service and we expect good quality food. Similarly, when they are paying us for the service for which they are not voluntarily coming, they are not happy to come. So naturally, they are likely to expect and demand service from us. As a result, I think our answerability has gone up. Plus, I think we all have seen aggression and stress increasing. Do you agree with me on this?
Yes, yes, absolutely.
And it is not just with the patients. I think even the healthcare professionals are now aggressive
Yes.
and stressed out.
Now they are fatigued and stressed. Yeah,
Fatigue.
completely.
And especially this COVID time has really, affected each one of us very badly. And you can see it right on their face and in their behavior. As a result, I think the patient-hospital conflict is on the rise. Over and above that, even media participation has gone up, and we all know media never portrays a very just picture to the society. It's usually with the idea to increase their TRP, to increase their readership. So therefore they would quote and place anything and everything without checking or verifying the truth or the fact. And as a result, I think the overall picture of healthcare delivery system is going down in our country. Plus, I think the problem of litigation is also increasing. We are seeing more cases against the hospitals and doctors, litigating for the negligence or for overcharging or for many other reasons. Plus, over and above that, I think the extent and the type of fights have changed. Earlier, it used to be usually verbal, but now I think very quickly it turns into physical violence and breaking of hospital equipment and hospital furniture, and also assaulting the doctors and the other healthcare providers. So I was taking a session for a group of medical superintendents of Delhi government hospital. So they were 35 of them, and they were sharing their experience. And one of them said that in his hospital, one of the junior resident had an argument with the patient's attendant, and everybody was around, so they controlled the situation, and they could make sure that they did not get into physical fight. But unfortunately, when the resident was going out of the hospital, the family members of that patient were standing outside waiting for him to come out. They physically assaulted the doctor, and he had almost like 15-16 fractures on his body. So you can imagine the kind of the extent of fights or the extent of violence that we are experiencing. So all these changes bring us to a point where we really need to sit and introspect. Is my communication with my patient okay? Is my behavior with my patient appropriate? And we really need to now work on this area where we focus all our energies on patient hospital interaction. And probably that is the reason now we are valuing the communication and interpersonal skills for all healthcare providers, because it is not just the doctor or one person who is interacting with the patient. Person from the security to safety to front desk staff to the general duty assistants, everybody is interacting with the patient. And we all know that most of us do our job very well, but when it comes to giving them a respectful service, a willingful service, a positive attitude service, I think that is where we are actually finding a great constraint. Incidentally, the training that we have for doctors, for nurses, for paramedical, it's usually very tubular in approach. It focuses on what they need to do. So even for the medical doctors, I think the focus is on the medical knowledge, on the clinical skills. Whereas to deal with patients or public or with their family member and even the colleagues, you require a different set of skills: communication skills, interpersonal skills, management skills. And unfortunately, none of the training program directly, addresses these skills. It is assumed that you will be knowing this or you already know it. Yes, some of us are really good at it. But what about those who lack these skills? And we all know, I was reading a study 7 out of 10 people lack on communication and interpersonal skills. Imagine the data. So you can well imagine how serious is the problem. On the other side, a study by Harvard says that 75% of our personal and professional success comes from our communication and interpersonal skills. Whereas the investment in terms of acquiring these skills is just 25%. So huge gap in the need or the demand and what is existing in the reality. On the other side, studies suggest that patient-doctor communication is often inadequate. We like to talk very little with them. We do not like to discuss about the different options. We do not like to give them all the details for various reasons. A lot of time we say we don't have time, or we are in hurry, or I have a lot of patients to see. But as a result, we like to have very minimum interaction with the patient. I'm showing you a slide. I would ask you, all of you, to read this paragraph. What did you understand? Probably nothing. Or maybe a little bit, especially those of you who are fond of chemistry, maybe they could immediately infer what exactly it is. This is what exactly happens with the patient and their family member when we explain them about their diagnosis, their treatment, or their intervention. The vocabulary we use, the speed we use, the tone of voice, the way we interact, it's so sometimes intimidating that they don't understand much, but they will never say, I have not understood. Most of them will be nodding in yes, 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 I'm getting it. But studies suggest half of them do not understand anything when we explain them about their treatment protocol or their diagnosis or the intervention. Some of the studies also suggest that when it comes to practicing informed decision making, our communication does not meet the basic standards of informed decision making. So when I take session from a group of doctors, I ask them, how do you normally, get consent for any treatment? So a lot of time they'll say, earlier, if you remember, maybe 20, 30 years ago, it used to be the nurses who would take the consent. Am I right? It would be usually the nurses who will be taking the consent. But now, yes.
Even
yes,
now.
Yeah.
Even now.
Now.
Even
now.
now.
Even now. So in some of the hospitals, even now, it is the nurses who are taking the, I completely agree. Whereas the protocol is, the requirement is that we are supposed to give them complete information and, make them, make a choice. They'll allow them to take a choice, but we do not, give them complete information. Any idea why we don't like to share the complete information with the patient? Why do we hesitate?
Two things. Can I come in? Sorry.
Yeah.
Two things. I feel first is we actually judge them that even though explained, it's not necessary that they would understand.
Yeah.
Let me treat and they will be benefited and they will understand.
Yeah.
First is this, and second is the workload, or I'm too much occupied with my commitments or my routine that I don't find I'm not able to spare adequate time to make that conversation with the patient. So probably I feel commonly these are the two things which I see.
Agree. Yeah, Pooja, you have raised your hand. Any other reason you think why we hesitate sharing all this information?
Yeah, ma'am. I think we have a tendency, means we avoid to have questions, back questions from the patient side. I think just we want to save our time, maybe.
So we feel that we will not be able to handle so many questions, so we kind of avoid, giving them all information. Agree. Dr. Pai, you raise your hand. Anything?
Yeah. Yeah, madam. Two things. One, I feel we don't give enough respect to the patient. Consider him part of the, as we earlier discussed, making part of the treatment, protocol or whatever we were discussing. Secondly, we are overconfident. We think that it is a simple, hernia surgery. Why should I, waste my time, explaining all the complications? I have done hundreds and thousands of them, so nothing to worry. So This both little bit of these two also adds to
Quite
the
possible.
sorry.
I'll just add, Dr. Hindu, that it is the ego that they think
Yes.
that they are demigod, they are semi-gods, they're
Yes.
almost gods. And so the patient is nothing.
Yeah.
Patient is a machhar, a makhi, and so they don't feel the need that I should tell him extra.
Yeah.
Why should I convey? That
I
is
agree. I
That's
agree completely. So see, we can see a lot of reasons. Any other reason that you think besides what Dr. Pinky, Dr. Pai, and Pooja has, identified, and Sandhya ji has also. Yes, yes, Dr. Radha, go ahead. Yeah.
I think now the doctors want to earn because obviously expenses have become so much. Even to work in a corporate hospital, we have to spend also. So they want to see as much as possible, be patients possible in a short span of time to get more income. I feel that is one of the big reasons you don't spend time with your patient.
That could also be one reason. I completely agree. I completely agree. I was taking a session for a group of anesthetists. So one of them shared his experience. He said, ma'am, a patient had come for PSC and she had to undergo foot amputation. She was around 45, 50 years old lady, and she had to undergo foot amputation. While doing PSC, in a very casual way, I asked her, from where are they going to amputate your foot? She said, amputate my foot? I never, I was not informed that it's anything to do with amputation. He said, go and see this doctor. And I thought, he's a doctor and he has sent me to you. You are a doctor, so you're going to examine some other part of the system. So I came to you and I have no idea that I'm going to be, my foot is going to be amputated. Now imagine you have already planned such a huge surgery for a patient and you have not discussed. Although everybody knows you cannot do it without taking patient's consent and without informing her. But then what about patient's mental preparation? It's a huge thing for the patient to, even a small finger, if you are going to lose, which has not much role to play in your functionality, is a painful idea. Losing a foot is going to completely change a patient's life. And I'm not, wanting to tell till I have already 100% planned and, done my job. One of the reasons why people do not like to share all information is they fear that the patient might run away. The patient might not get the surgery done. The patient might not get the procedure done. So therefore they kind of avoid giving all information, because then we'll have to discuss a lot, explain a lot. But let me tell you, I think with the changing time, it's very important to discuss a lot of things essential to be discussed with the patient, so that tomorrow patient does not tell you that you did not share this information with me. And especially the kind of litigation cases we are seeing, patient can sue us for various reasons. This is one of the very common reason that I was not explained or I was not told. So I think we really need to focus on it. Another thing that we read from the studies is that we do not consider the family as the beneficiary of our care. We look after the patient very well, but when it comes to handling patients' families, concerns, we sometimes do not consider them, important, and we do not address this. And as a result of all this, I think there's a huge communication gap leading to, leading to frustration and unrest and, violence against the hospital and the doctors. Another major problem is a lot of us think clinical communication is about niceties. That is why most of the people are not interested in learning clinical communication, because they think it's more to do with hospitality. So clinical communication is not about niceties. It is about patient's medical information. Communication that happens with the fellow professionals and with the patient and their family member. And it has direct impact on the outcome of our services. So clinical communication has to be taken seriously if we understand the ill effects of not communicating effectively. According to a study by JCI, I'm sure most of you will be knowing, medical errors are third commonest cause of deaths. And this is a study in US, not in India. Had we done it in India, I don't know where we will be, or even in Bangladesh. Can't say where we will stand. But definitely it's very alarming. If a country that works so systematically, this is what is their situation, I don't know where we stand. And most of these, medical errors that happen in patient care are around, wrong site surgery, wrong medication, wrong organ removal, wrong treatment, and wrong patient. So you can imagine the extent of errors that are happening in patient care. A study by Professor Ashish Jha, it estimated 5.2 million medical errors annually happening in India. Again, I feel it's underquoted, underestimated. It must be much more than what it is seen here. And most of these errors are around medication error or patient care or surgical errors. So imagine the extent of errors that are happening in patient care. So it's not about just, niceties. This is the major reason why we really need to ensure that we communicate effectively. Incidentally, most of these cases do not get reported. Only 3% of the errors get reported. 97% of the errors are brushed under the carpet. Probably that is the reason why we are not taking this very seriously. And most of these errors are due to internal communication failure. We think it is the patient who does not understand, or it is the patient's attendant who does not understand, but it is us who are making these errors. So we are going to do a small activity. I'm going to take 5 of you out of from the main area to the waiting area. So I'm not like choosing anybody. I'm taking random from 1 to 5. So Captain Sandhya, I'm going to send you to the waiting room, and I'll be taking you in a while. Okay, put in the waiting area. Yeah, Dr. Rajesh, I'm again sending you to the waiting area.
Okay.
So I'll call you in. Next is Dr. Leah Raj. So again, I'm sending you to the waiting room. Next is Dr. Anup. Putting in the waiting area. So 4 people have gone. So 1 more I need to send. Okay, Dr. Bala Murugan. So I'm sending you to the. So I'm not choosing anybody. It's just on the participant list. Whoever is coming first, I'm sending them. Okay. So 5 people I have sent them in the waiting area, and I'm going to show a slide to. Okay. So who would like to participate? Who would like to do this activity with me?
Yeah, I would.
Okay, thank you, Dr. Pinky. So Dr. Pinky, I'm going to show you a slide which you need to read, and once you are done, you just need to tell me, yes, I am ready. Okay, and others will keep observing quietly, and observe and make note of whatever you observe, and then when we have discussion, you need to share your observation. So I'm sharing this slide which everybody can read, but you have to read it for yourself. Yeah. Ready? Okay. So I'm going to stop sharing now, and I'll be getting the first person in, and that will be, okay. Okay. So Dr. Rajesh, I'm admitting. So whatever you have understood by reading that slide, now you have to share with Dr. Rajesh. So let me come in, let me tell him what he has to do, and then you can start sharing the information. So Dr. Rajesh, are you there? Have you been able to join? Yeah, okay. So Dr. Rajesh, if you could unmute and say that you can hear me.
Yeah.
Yeah, okay. So Dr. Pinky has a set of information she's going to share with you. So please listen to her carefully. Ma'am, please go ahead.
Okay. So this information, sir, madam has showed us a slide which says that there is a patient who's suffering from tuberculosis, and the family, he's been in the ICU for 5 days, and the family has spent almost 5 lakh rupees, and the family is very concerned about the recovery of the patient, and the patient's son probably is the sole bread earner for the family. So this is the case scenario.
Okay, thank you, Dr. Pinky. So from here on, Dr. Rajesh will take over. And Dr. Rajesh, now you have to share this information to the next person whom I'm going to get in.
Okay.
Give me a second to admit Captain Sandhya. Okay, so she's joining in. Okay. So Captain Sandhya, Dr. Rajesh has a set of information he's going to share with you. So please listen to him carefully. Dr. Rajesh, please go ahead.
So this is about a patient who has been admitted in the hospital. Patient has got a very severe form of tuberculosis and is had a long stay in the hospital, and already the family had spent a lot of money on the treatment of this patient, and there is only one sole bread earner for the patient, who is his son, and that is the info I have received.
Okay, thank you so much, Dr. Pai. So from here, Captain Sandhya will take forward. So Captain Sandhya, I'm admitting the next person, and you will have to share this information with the next person. Give me a second. Okay, so I am admitting. Why can't I see their name? Okay, so I'm admitting Dr. Bala Murugan. So please, whatever you have understood, you need to share that information with him. Okay, so Dr. Bala, Captain Sandhya has a set of information she's going to share with you. Please listen to her carefully. Go ahead, ma'am.
Dr. Bala, I have some information for you. So
Yes.
there is a patient who is admitted in the hospital, and patient has got some serious prognosis, and has been admitted in the hospital for a long time. And of course, his family has spent a lot of money on the treatment. And the patient also has only one blood runner, I think his son, to run the family after him. That's all. I just thought I'll inform you and update you on that.
Thank you so much. Thank you, Dr. Sandhya. So the next person who is coming in is Dr. Anup. So Dr. Bala, whatever you have understood, you need to share this with Dr. Anup now.
Okay.
Thank you. So let him come in and let me explain to him about the activity. Okay. So Dr. Anup, Dr. Bala has a set of information he's going to share with you. So please listen to him carefully. Dr. Bala, please go ahead.
Okay. Sir, I have information for you.
Yeah.
The patient admitted in the. So is it audible, sir?
Yeah.
Yeah. So the patient was admitted in the hospital. Patient is having a serious prognosis. So they have spent a lot of money in the hospital, and they have one breadwinner, the family, one son. Okay. So this is the information I got to transfer to you.
Yeah.
Okay. Thank you, Dr. Bala. So Dr. Anup, I am admitting Dr. Leah. So whatever you have understood, you need to now, share that information with Dr. Leah. So Dr. Leah, Dr. Anup has a set of information he's going to share with you. So please listen to him carefully. Dr. Anup, please go ahead.
Yeah. There's one patient admitted to the hospital who with a very poor prognosis, and he has a son who is the only breadwinner of the family. Yeah, I think that's it. Yeah.
That's all. Thank you. Thank you, Dr. Anup. Thank you. So Dr. Leah, whatever you have understood, please explain to everybody.
Okay, so there is a patient who is admitted in the hospital and who has a son. This patient has a very poor prognosis, and he has a son who is the only breadwinner of the family.
Thank you. Thank you, Dr. Leah. So friends, what happened?
So much has been lost in transferring.
One information survived accurately. Another information is gone.
You know, patient handing over is considered Bermuda Triangle of healthcare. And you could see it right here. Especially, you know, a patient's information exchanges so many hands that by the time it actually reaches to the point, it has lost its meaning. So one by one, if you can tell what got lost, one by one, just give one answer. What do you think got lost one by one?
The diagnosis itself.
Okay, diagnosis lost.
I think when I conveyed, I think the name of the patient was lost.
Name of the patient was lost. Very right. Okay, very right. Serena, what did you identify? What got lost?
Yeah, of course, the name, the age also. It's pulmonary tuberculosis. So it was just, then it came to certain ailment. All right.
Yeah.
And yeah, 5 days in ICU was again lost. Yeah.
Okay, let's ask others. Okay, Pooja, what more got lost in that process?
Unmute.
Pooja, unmute your device.
Yeah, sorry.
Yeah.
So Mr. Ram, patient of 65-year-old male, and he was diagnosed with
besides it, what else was
tuberculosis.
lost? All
And he
this
was
they have
being
said.
admitted for 5 days in ICU, and family.
Pooja, what other thing got lost in the transfer of information? Name, age, diagnosis, all got lost.
Age.
That was already identified. What more? What more?
Cost.
Okay, the expenditure. Yeah. Very right. Okay,
Yeah.
Dr. Saifuddin, what more got lost in that process?
5 lakh rupees.
5 lakh rupees got lost. They spent a lot of money. They spent a lot of money. How much? How much? Okay.
I think 5 days. 5 days become long stay.
Long stay. Yes. And diagnosis became
severe
prognosis. Serious prognosis.
But an important thing that the son wants to meet doctor, that concept.
Exactly. That point, I don't know where it completely, that was the major thing. If that was communicated that, okay, patient's son is the only breadwinner and he has spent so much of money and he wants to talk to us about the expenditure or care or outcome, whatever his concerns are, that point got completely lost. And Dr. Leah and Dr. Anup, when I will show you the original information, you will laugh at the information that you got.
Laughing.
And trust me, this activity brings such funny results that patient Ram, his son is admitted, he's 5 years old, and he has nobody to look after. I don't know what all versions we get. And imagine, this information is so simple. And people who are handling this information are daily using this vocabulary and this information. It's nothing very difficult or very complicated. And this is what exactly happens when the patient gets, moved from one care area to another, the information gets lost. And that's why the patient's safety is majorly affected because of this. So I hope this activity will always remind you of this is basically Chinese whisper, but I have used it to my advantage to this, this topic. So as I said, this was the information that was shared with Dr. Pinky. She tried to give almost everything very meticulously, but after that, unfortunately, slowly it got lost. The major reason why it got lost was that we were relying on memory. If any one of you had noted down the points, what the first person was saying, you would have definitely been able to remember a lot of it. And second thing that we do not do usually is to check back, to ask, it's not clear, can you explain to me once again? Or the person who is giving the information can check with the person who is receiving, is it clear to you? Have you understood? Do you want me to repeat it? there's a technique called teach back. So when you ask the person to say, okay, have you understood? The person says, yes, I have understood. Tell me, what have you understood? I mean, there were so many ways that we could have ensured that this information does not lose its meaning. But I'm sure you got to see how the whole information got distorted in that process. You know, poor communication is the lead cause of medical errors and the lead cause of violence also. 60 to 70% of the medical errors are a result of poor communication. And 50% of times, the patient's concerns are not asked and they are treated based on assumption. So you can very well imagine the kind of errors we make. So can you tell me, you know, in a simple activity like a blood investigation, maybe CBC, or maybe, you know, any other blood, how many people get involved in that process? Can you calculate and tell me? You can even note down in your notebook so that you know whom I am counting.
As per me, 8 people who are performing the blood test, like a particular test. If I just leave aside the suppliers, then the 8 people in the hospital who are directly involved.
Just imagine, for a small activity like a simple blood investigation, 8 people are involved. So that many opportunities of errors. That many opportunities of error. So really we need to understand that it's not just simple blood collection, but everybody who is going to handle that information has a risk of, you know, missing the information and creating this thing. So in a average, in a stay of say 3 to 4 days, how many people handle a patient's information? Again, just guess.
Must be 30, 40.
Very close to the guess, almost like 50 to 60 people.
10 people per day, you can say.
And again, that many opportunities of error. So clinical communication is all about making sure that the information is, you know, forwarded in a manner that is well received, well understood, well implemented. So communication is also about better coordination between healthcare providers. We'll be talking about it at length when we'll talk about the handing over tools, especially when the information has to be shared between 2 different categories of staff, consultant and resident, consultant and nurse, technician and consultant. So there's a huge hierarchical gap. So as a result, there's a great risk of, you know, communication failure and possibility of error in patient care. So if we communicate effectively, I think the major thing that we are concerned about is continuity of care and patient safety. That can definitely be looked after. If we are able to ensure all these things, I'm sure the communication, the medical errors will get reduced and automatically it will improve the healthcare outcome. So it's not just about niceties, it is about the clinical communication of the information, medical information of the patient. That matters a lot. Now, besides this, there are a lot of sensitive, intense communications like breaking of bad news, end of life care, grief counseling, or handling an aggressive patient party. All this requires advanced communication skills. Now, unless these skills are learned, very difficult it is to actually do this, you know, communication effectively. If we communicate effectively, I think even the risk of violence and litigation would go down, because studies suggest in 71% of the cases where the patient had sued the hospital or the doctors for medical negligence, the root cause was communication failure. When they were not informed, when they were not explained, when their concerns were not addressed, when they were not updated, when they were not even, given the opportunity to express what they want, that is where they ultimately, get into, the litigation, to the point of litigation. If we practice these skills carefully, I think all this will ensure greater patient satisfaction. And studies suggest our interaction decides where, have we talked about ABC of patient satisfaction? Can we spend 5 minutes discussing about ABC of patient satisfaction? Any idea about ABC of patient satisfaction? For any healthcare facility to earn patient satisfaction, we require A, B, and C. A is ambience. C is the clinical services that you provide. And B is the behavior of all the staff members, team members. Now, if I consider three of them equal, so that means each part would give you 33% of their input. Ambience, behavior, and clinical skills. But studies have shown that even if your ambience and your clinical skills are average, but if the behavior of the healthcare providers is good, patient satisfaction is much higher. Then when you have good ambience and good clinical services, but the behavior of the patient is not, behavior of the healthcare provider is not appropriate. So for any healthcare facility to succeed, we have to focus on majorly these three areas. We have to make sure that we give them the required services. Clinical services are good, but at the same time, the healthcare provider's behavior is, respectful, willing, positive attitude, which we'll be discussing in the next session. We'll be discussing at length. So as I said, if you're able to ensure this, you will actually earn a greater patient satisfaction. And it's not just about the patient. I think even we need to be satisfied when we are, providing a service, because at the end of the day, it is not just the money or the reputation, it's your personal satisfaction that matters a lot. So proactive communication with the patient, with their family member, and with your team member is definitely going to earn you enough professional satisfaction to go to your bed, comfortably in a very cheerful manner. And if you can ensure this, I think that's the real purpose of learning clinical communication. So in nutshell, clinical communication is therapeutic communication that happens between us and the patient. It is the clinical communication that happens between the healthcare providers about the patient information. It is not optional. It is part and parcel of the overall treatment of the patient. A lot of time we think, I'm giving good service, so why do I need to talk? I remember in one of the hospitals, one of the very senior doctor, I really could not, at that moment when the way he said, it came as a shock to me, coming from such a senior person. He said, I have a huge queue of patients waiting for me. And they're very satisfied with my outcome. Why the hell I need to communicate? Now imagine if that's the thought process in the background, what will be the communication of this person? And I'm sure you all must be seeing this kind of arrogance among a lot of established clinicians who believe that communication is not required. It's just the outcome that matters more. Let's understand that implementing these communication practices has a direct impact on the continuity of care, patient safety, and treatment outcome. And if we can ensure this, I think that's the real purpose of the service. There are set communication protocols. A lot of them we are going to discuss in the coming sessions, which every healthcare professional must know and practice them. So with your team, with your subordinates, with your peer, with your staff members, you'll have to make sure that they are aware of these protocols and they practice, they learn. It's not just on the paper, but it's actually implemented in real sense. And there are multiple ways to learn and implement these skills. I think training and skill empowerment is one way which we can all adopt. Thank you. So this is in nutshell about, the topic that I wanted to start with. What is the importance and relevance of communication in healthcare? Although I know all of you are already, well versed with. So very quickly, if anybody has a question around it or any comment to make around this.
First, a small question is, will we get these slides?
So you will be getting a YouTube link to the whole recording.
No, I'm just thinking that in case we want to use these slides as a
I can give it, but I will always say make your
own slides.
I will advise you, because then you will be able to put your heart and soul to this slides.
Correct.
That's my understanding.
Okay, madam.
So, but otherwise, I think these things are, and the content of the slides is already there in your content.
Yeah, it is It is there.
It is very much there. I've given there, yeah. But I would still love to see your personally designed, then you're able to think and put in more ideas. That will be good, yeah.
Absolutely.
Yeah, Dr. Saifuddin, you have something to say. Go ahead, please.
The data you have mentioned in the presentation, so if you provide the references for those data, then it will be more effective or meaningful for us to communicate.
Very much. I was going to request for that. I was going to request.
I will do that. I will do that. Actually, just to share with all of you, this is one book I have written. I don't know if you can see the name. This is Fundamentals of Clinical Communication. So this book has everything that what I have talked about with references, with all the detail. But those references I can definitely share with you. That's not a problem. I can pick up from the book and I can share in the group. That's not a problem. And everything is well validated, well documented. So nothing arbitrary. Thank you. Yes, Dr. Pai, you have something to say. Go ahead, please.
Yeah, actually, the quality movement started in US based on a study by Institute of Medicine. They published a book called Crossing the Quality Chasm. And in that, they have mentioned that this is 1998. They mentioned that at that point of time, there are 3.5 lakh, medication errors happening in US.
I'm sorry, I can't hear you, Dr. Pai. Sorry, I don't know if others are able to hear. Yeah.
There are some 3.5 lakhs of medication error happening in US in 1998. And today it is much more than that, And US government is spending billions of dollars for the care of these errors. So this is how the quality, that movement started in the US. And they made that Institute of Healthcare Improvement, Don Berwick and other people. So
completely, I agree. Recent studies say that around 98,000 to 250,000 patients die every year because of the medical errors. In US.
Yes.
India, we haven't done any study. I'm sure we will never do such a study. But that's the reality. And I still feel it is under, quoted, under mentioned.
Madam Saifuddin is listening, so be careful. He won't send patients to India.
See, to make sure that he sends more patients, I think we need to improve the quality of our service. And whatever lacunas are, we need to work on that. By covering them up, that will not, make sense. We need to really, and it's not just for, of course, medical tourism is a big thing now. I know that very well. But at the same time, serving your own countrymen, we need to make sure that we look after their safety. It could be our own family members ultimately from the society. Yeah. Any other question or any statement? Yes, Dr. Anuradha, please go ahead. Yeah.
Dr. Indu, just one thing I want to know, like we talked about communication protocols.
Yeah.
But like there was an incident that you shared that a senior doctor had a long queue of patients, so he didn't want to spend. So this is a real problem also in the world, that we have long queue of patients and we don't want them to wait for long hours. So does this protocol also give a solution how to manage in such situations?
Wonderful. Dr. Anuradha, I think you are really listening to what I'm saying and you are asking a very pointed question. Friends, when I started my training program, initially I did 500 training programs for government hospitals. My first beginning of communication program was with the government hospital. I did one program in Lal Bahadur Shastri Hospital. The medical superintendent was so impressed with the session. She just wrote to the health secretary that get this session done for every hospital, for as many, healthcare providers as possible. For 2 years, every day I used to go to one or the other hospital. And these types of questions were asked to me very often, that do you know the amount of patient we are seeing? Do you have any idea the number of patients we are seeing? I completely agree. And then I started, finding answers to this question. So I'll quickly give few solutions to what the question that you have asked. My first answer is, communication is not what you say, it is how you say. For example, if I'm eating my food in my room, and if a patient comes in, and if it's a government hospital, what is the way I normally behave? भैया दिखाई नहीं दे रहा, खाना खा रहे हैं, बाहर चलो, गार्ड इनको अंदर कैसे आने दिया आपने? I spent, I think, 1 minute or maybe 30 seconds. Instead of that, if I had said, आप थोड़ी देर बाद wait कर लीजिए, मैं खाना खा लूं, अभी आपसे बात करती हूँ. Time taken would be same, but it is how we communicate that has the impact. So all these small things add to, irritation to the patient's family. That is one thing. Second thing, when you're talking about the time factor, I always tell them, have you heard of Pareto's law? Has anybody heard of Pareto's law? Because we have a lot of people from management.
Yes.
Wonderful. So ma'am, could you please explain Pareto's law for us?
Pareto's, as I remember, is 80-20 or 80-20 law, whatever it is.
80% of problems. 80% of problems are caused by 20% of that.
So if you take care of that, so
correct, very right. Dr. Saifuddin, you want to add something to it?
I think it's okay. 80% because of 20% causes and 20% because of 80% causes.
Okay.
So if we address 20% causes, we can solve 80% problems.
So just to explain to everybody, Pareto was an economist who gave this law that 80% of the economy is in the hands of 20% of people. And it is a universally applicable law. If you try to apply the same law to your patient handling, 80% of the patients would be such who will not require much detailed working. If you will see in your OPD, even with giving 2 or 3 minutes, because in a place like LNJP where I teach medical students, we have calculated they see around 80 to 100 patients in 4 hours. So that means 20 patients per hour. That means not more than 3 minutes per patient. So even there you can apply your Pareto law, where you can quickly, get going of this patient who does not require much detailed working. But patients who require detailed working, they have to be identified and they have to be given time to make sure that you discuss at length with them about their diagnosis, their prognosis, their treatment, and their intervention. The problem of not talking is the students normally say, when I ask them, do you build rapport? They said there's no time. I said, building rapport does not require time. Now tell me, did I make any effort to build rapport with any one of you? No, but I've already built my rapport with all of you. It is not a question of time at all. It's a question of readiness. Do I want to? Do I value it? Do I consider it is important?
And madam, the way to identify this 20% of irate patients or whatever, likely irate patients, would be just your sixth sense or your, the kind of how you pick up, with experience.
Studies suggest when you do a doctor-centered practice where you don't allow the patient to say anything or ask anything, you would spend around 7 minutes and I think around 45 seconds. And if you allow the patient to ask, or even in the end, if you say, do you have anything to ask? Do you want me to explain you? They will take additional 1 minute. But the patient satisfaction will multiply many, many folds. Only thing is I need to value that in the end, I need to ask my patient, is there anything that you want to ask me? Do you have any question? Whatever I have said you, is it clear to you? Dr. Bala, you want to say something? Please go ahead. Yeah.
Yeah, it's not a question, ma'am. It's only a doubt.
Sure.
So when the doctor, after the PG, when they're starting the career, the initial days, they'll speak a lot with the patients. They'll spend more time.
Yeah.
They'll explain properly. But when the experience goes, when they have experience more than 5 years or more than 10 years, the number of words they are speaking with the patient is actually coming down.
Yeah.
So what is the reason or how they it is?
Again, because the tendency to ask closed-ended questions, tendency to ask leading questions, thinking that this will get me more information and it will save me time. Whereas studies have said, if you ask an open-ended question to your patient and allow the patient to speak, they can tell about their problem in 50 to 60 seconds. And that will get you more information to make an accurate diagnosis. 50% of the diagnosis can come from asking an open-ended question and listening to your patient.
Okay.
But because this is not taught, so this is not valued, this is not practiced. So we think asking closed-ended questions, leading questions will give me quick answers. Then you may forget to ask an important question. You may miss on the information.
Okay.
Yeah.
Yeah.
Yes, Dr.
In this era of EMR, doctors sometimes even don't find time to look at the patient.
Yes,
You know,
yes, very right.
they're
Yes,
all the
very
time
right.
looking on the computer, and your X-ray looks okay. The patient's face, at least you look once. The patient
Yeah,
satisfaction will
yeah,
go up.
yeah. So with Maulana Azad Medical College for the last 10 years, I'm working with their final year students. So before they go for their internship, it is mandatory for them to take 6-hour training. So I get students in the batch of 30-35, and we did do 9 to 4 training. And I'm majorly focusing on one thing, and that is conducting patient interview. So I'm training them through activities, role plays. How do you go about, conducting patient interview? How do you collect information? What should be your way of asking question? How do you make your patient comfortable? How do you build rapport? How do you listen to your patient? And they do role plays, and a lot of videos we see, and that's all. That's what we are doing. And I think this is one college who is very religiously doing this program for almost like 10 years. I haven't seen any other medical college doing this in this meticulous manner. That's the thing. Yeah, but I think hopefully in the time to come things will be different. So in the era of EMR, I know it's important to put everything on the EMR, but at the same time, I have to create a balance between what I'm doing on the laptop and then looking at the patient or interacting with the patient in the right way. But I completely understand your concern. I agree. I completely agree. So any other question about the discussion we had, or anything you wish to add? So with this, I think we'll end, but I need to share a feedback form immediately with you. Very small one, just quick one, not a very big one. I'm sharing the link in the chat box, and you're requested to give your feedback and before we leave. Yeah. So I've shared the link. Please see if it's working.
Yeah, it's working.
Thank you. Thank you. So next session we are going to have on next Friday. So this schedule will be on Friday, Saturday, 8 to 10. Is it comfortable to everybody?
Yes.
Friday. Okay. Can we have it from 7 to 9? Just
I am okay if everybody else is comfortable. We can actually raise hand and see if
Friday, 28th, isn't it?
28th, yes, Friday 28th. I'm okay 7 to 9. If everybody's okay, I think we can change the time from 7 to 9.
Yes.
I think almost everybody is ready. In case if anybody has objection, you can actually say no, then so that we know.
So it would
Captain
be
Sanjay, I have
7 to
another.
9 every time or just for Friday?
No, I won't be able to attend 7 to 9. Saturdays, it is not possible. I have another class up to 8.
Is that Dr. Anuradha speaking?
Yeah.
Yeah,
Because
then
your
ma'am, we can
camera is
have it
off.
8 to 10 then. 8 to 10 is fine then, ma'am.
No, Dr. Anuradha, Friday we can take 7 to 9 and Saturday 8 to 10. Is that okay?
That is okay.
Okay. Is that okay to everybody? At least one day we get 7 to 9?
Yeah.
Yeah, I remember Dr. Anuradha was saying she's attending some program.
So Saturday is 29th, right?
Saturday is 29th, yes.
29th. 29th, 7 to 9, right?
28th, we will be meeting 7 to 9.
Okay.
That is Friday.
No, I think Friday Dr. Radha has an issue. No?
No, Saturday she has.
Saturday.
It's a Saturday.
Saturday.
So if we are having it on Friday, 7 to 9.
So we can do it this way. Every Friday we can
Yeah.
keep 7 to 9 and Saturday we can keep 8 to 10. Okay?
Yeah, that is good.
I hope everybody has done.
Yes.
I will be traveling on 2-3 weekends in February, madam. 1 or 2 weekends in February. So that time, I don't know. We'll discuss that time.
Try if you can be available, because see, it's all activity
So 8
based.
to 10 should not be a problem.
Yeah. Try to keep yourself free at that time, because that's the real purpose of the program. No, otherwise material you can get ample on Google. Yeah, it is a learning by interaction. No, learning by interaction. That's the thing. So I've received 9 responses. 2 more are to go. Who all are still doing?
I'm doing, Dr. Hindu, just finishing up.
Okay, no problem.
I'm not sure whether my form got submitted or not because I got logged out accidentally.
Let me check. No, I have not received. Yeah.
Not received?
No. So should I share the link once again?
Please. Yes, it's not.
No, not
visible.
It's a small. That's why I've kept the feedback form very, very small to get the real feel from all of you, in case if there's anything that I can modify in the next session.
Just.
So anything that you would like this session to be modified, like in future, for future participants, or is this okay as an introductory session?
Well, I felt it is beautiful. It has given a good perspective.
See, that was the idea. I know many of you are very experienced, and for you it may be kind of a repetition or something, nothing new. But then I thought everybody should come on the same page so that we can start from here. So I decided to have this as a baseline session. The second session will be on developing communication competencies, where we are going to talk about verbal and non-verbal communication in detail. Again, lot of activities, lot of questionnaires, lot of action, so that we learn by doing. That's the idea.
Yes, madam. It was nice actually. But madam rightly said, different perspective. Yeah. And because normally, these kind of perspective is not discussed in hospitals.
Yeah. Yes. Yeah, that is true. I completely agree. So I've received 11 responses. Thank you so much. Thank you for being patient with me and being here till 10:10. I have taken away another 10 minutes of yours. You have all been a wonderful participant, wonderful audience. Thank you so much. God bless.
Thank you, madam. Yeah. Thank you, madam. Good night, everyone.
Thank you, everybody. Have a great night.
Good night. Thank you. Thank you.
See you soon. Yeah.
So I'll share the recording.
Yeah.
Sure, ma'am.